Hello, my name is Amy Deacon, and I am the Director of Autopsy Services at Summa Health System, Northeast Ohio Medical University Residency Program. This is the first lecture in the PathElective Autopsy module, Introduction to Autopsy Pathology. First, let's start by going over some objectives. The objectives of this lecture will be to introduce important terminology, describe the differences in types of autopsies in the U.S. medical and legal systems, discuss the concept of informed consent regarding the autopsy procedure, introduce the players in the room during the post-mortem examination, introduce the most common instruments used in an autopsy exam, cover basic dissection approaches. As a medical student, you have likely participated in an anatomical dissection of the human body in your gross anatomy lab on an embalmed cadaver. This is an excellent hands-on method of teaching in order to learn the function and interaction of all the basic organs. An autopsy performed on a deceased patient is a very similar experience, but performed differently as it is for a different purpose. The word autopsy is derived from the ancient Greek and translated means seeing with one's own eyes. This literal meaning of the word gives understanding to what we are attempting to accomplish in the procedure. The procedure allows the physician to discover with their own eyes the ultimate cause of the patient's demise. Other words that are commonly used when discussing an autopsy include the word necropsy. However, this is more popular with veterinary pathologists who are performing post-mortem exam on animals. The current most popular term includes post-mortem examination. This is becoming the preferred terminology to refer to an autopsy, especially in the forensic community. The first type of post-mortem examination is that of a medical legal autopsy, which is mandated by the state. Laws governing the medical legal system in the United States vary by state where the death occurs. These exams are ideally performed by a forensic pathologist who has 3 years anatomic pathology only training or 4 years of AP/CP training and 1 year of specialty forensic pathology fellowship. These exams are initiated in deaths in which the manner of death is unknown or suspected not to be natural. This will be covered in a more in-depth follow-up lecture by Dr. Waite. Hospital pathologist performed autopsy can be initiated in two common pathways. The Hospital Quality Review Committee or Physician Review Committee may request an autopsy from the next of kin, or a physician involved in the patient's care can request an autopsy when there are concerns regarding the death with unanswered remaining clinical questions in the case of a natural disease. The family/next of kin may also initiate an autopsy request. These are generated for multiple reasons, but common reasons include finding closure with an exact cause of death, genetic concerns for surviving family members, and documenting disease for insurance or legal settlement purposes. Informed consent of the next of kin is required to proceed with an autopsy in the hospital setting. Laws vary by state, however, performing an autopsy without appropriate consent can usually result in some type of criminal charge, such as abuse of a corpse. When taking an informed consent for an autopsy, the items that need to be discussed include the restrictions for the autopsy, use of tissues for research, scope of testing provided by the hospital, return of organs with the body to the funeral professionals. It is important to manage expectations by discussing the expected turnaround time for all reports involved and any costs that the family may incur as a result of the autopsy. Most teaching institutions provide autopsy services free of charge to the family, but all aspects may not be covered, such as transportation from an outside facility or from their home. In order to become certified in anatomic pathology, pathology residency programs in the United States are required to provide education in autopsy performance and practice. The American Board of Pathology requires each resident to participate in 50 documented autopsy examinations to become certified in anatomic pathology or combined anatomic and clinical pathology. Most programs use a combination of hospital autopsy requests, pediatric autopsy cases, fetal autopsies, and forensic autopsy cases to meet this mandatory number of 50 autopsies. The teaching staff who participate in the primary autopsy instruction can vary by program. Limitations and restrictions to an autopsy examination. The next of kin can limit a hospital to perform only partial autopsies when giving consent for the autopsy. However, that can limit usefulness of the autopsy for particular purposes, such as documenting evidence in medical legal cases or accurately determining the exact cause of death. Limited autopsies also have a set, strict rule for medical education purposes, such as only 5 cases of a single organ autopsy, like a brain-only autopsy, can count towards a resident's required number of 50 required cases and cannot be shared between 2 residents. So the types of restrictions are external only, so you're going to only examine the body without cutting into the body or looking at any of the internal organs. Chest only, where you're only examining the heart and lungs. Chest and abdomen only, where we're going to examine both the chest cavities and the abdominal cavity, sometimes limited to no brain or no head, which would include all other organs of the body, or sometimes they are limited into only one organ to be evaluated. Now I'd like to introduce the key players in the autopsy suite during a post-mortem examination. In a teaching program, the resident pathologist is usually the one who completes the majority of the prosection with the assistance of an autopsy technician or pathologist assistant. The attending pathologist is usually a close observer to advise residents on the best course of dissection or identification of important gross lesions in ensuring that nothing is missed. It is not uncommon to have multiple observing or rotating medical students, such as medical students in their 3rd or 4th year of rotations. The clinical physicians may or may not be in attendance. Frequently, clinical teams will send one representative that participated in the care of the patient. In our institution, it is usually a medical student or physician assistant student that will report back to the main team the finding of the autopsy. What's in your instrument drawer? What items are hiding in the instrument drawer that we use on a daily basis during a post-mortem examination? One of the most important things that we use is the positioner. This is frequently called the headrest or head block in common terms. It is usually positioned under the center of the body between the shoulder blades. It's usually in the beginning of the autopsy, frequently used to extend the neck and allow you to have optimal exposure of the neck for dissection. It is frequently moved to the base of the skull to optimally position the head for the scalp to begin the incision to remove the calvarium and brain. I hadn't frequently looked at our head positioner, but since I was taking this photograph, I noticed that ours is actually engraved, so this is going to be belonging to our hospital forever. So it says Akron City Hospital on the inside of it. Instruments, these are the instruments that we use. They're presented here from left to right. The scalpel, which we use to make the Y incision. There's the dissecting probe, which can be used to check the patency of different small diameter lumens, such as ureters or the foramen ovale. There's next a ruler, which allows you to do accurate reporting of measurements, general knife, which requires sharpening with a steel, and a razor knife, which can hold replaceable razor blades. Our residents prefer to use these razor knives to the normal steel knives because they don't have to sharpen them. Once again, from left to right, these are the pancake forceps, which we use in our training program to teach residents to trim tissue sections to the appropriate small size to place in the tissue cassettes. Next are the forceps with teeth. These forceps with teeth are best for grabbing tissue such as adipose or decomposed tissues, which can be very slippery. Next are forceps without teeth, which can be just generally used to grab any tissues. Wire cutters, which we use to cut medical hardware such as cardiovascular stents or pacer wires. This is just a photographic example of what those forceps with teeth and forceps without teeth look like, and it also includes some different types of scissors. So there's blunt ended scissors, especially the one on the right, which is used for opening the bowel in order to not cut the mucosa or damage the mucosal layers as you're opening the lumen. So here's just a real life view of these. So there's a specialized bow scissor with the blunt leading edge, and it ensures there's no damage to the luminal mucosa while opening. The next thing is the example of a retractor, which may be needed to increase exposure for your dissection. There's a variety of sizes and scissors for sharp dissection when necessary. And frequently I use the hemostats and clamps for assistance with retraction, and sometimes I can use these for blunt dissection or in assistance with blunt dissection. And the last thing on the left, all the way to the left, the T-shaped item is the Virchow skull breaker, and this is used to put into the incision into the calvarium in order to open the skull with a twisting motion. Other tools that we can see here are in a drawing. We can see this chisel and hammer. Some people do use that to open the skull, as well as bone cutting forceps, which can be used to cut ribs, and the electric autopsy saw, which is frequently referred to by the popular brand name Stryker, similar to Kleenex. Stryker is a brand name, not the actual name of the saw. The electric saw has since seen itself replaced by the rib shears for opening the chest due to COVID-19 to minimize the autopsy staff's exposure to aerosolized bone dust. And you can see here these rib shears are on the right with the red handles. And then the one on the left is actually just a regular handheld bone saw that we sometimes. The external examination is the first component of the autopsy. In a forensic exam, this is usually the most lengthy process. This should be done in a routine way so that no aspect is forgotten. In a forensic exam, the trace evidence is collected first. If it is not collected at the scene, such as fingernail scrapings and clippings, fingerprinting the body, swabbing body cavities or bite marks, examination and remove and preserve the clothing, collecting hair samples from the decedent, combing the pubic area and any adherent hairs or fibers to the body, collecting those for trace evidence. Photographs should be taken both clothed and disrobed. Features of identification are recorded at this time. Features of identification include tattoos as well as scars and any identifying things special to the patient. In a hospital autopsy, the most important aspect of the external examination are the features of identification and evidence of medical therapy. So documenting medical therapy includes photos of dressings, recording dates and initials written on dressings, recording the presence of all tubes, lines, and devices, as well as all scars and surgical incisions. Next would be recording any evidence of trauma that you would see, any bruising, any cuts, any scrapes, any obvious broken bones in forensic cases. And then last is any pathology that you would see on the exterior, such as usual findings would be something like a skin lesion or an obvious mass or a lump somewhere on the body. During this stage of the exam, usually the vitreous humor and peripheral blood are collected from the femoral vein in order to use these in toxicology studies and post-mortem chemistry examinations. Then we're going to start the dissection, and there's several ways that you can do the dissection, the internal examination. And in general, I have used the organ by organ technique when I begin training, which is the technique that's popularized and sometimes called the Virchow technique. The en bloc resection is preferred by many because it keeps the anatomy intact, and this is called the Rokitansky technique. Or you can use a combination of both techniques, and these all have various names depending on how they are put together. So basically, you're trying to take all the organs apart and look at them individually. This short demonstration, because there's not a video included, for those who watch me who are listening that know me, you know I'm a fan of old and rare books. This is one such book with detailed illustrations of the autopsy procedure from 1962. While we are hoping to include some dissection demonstration videos in this course for lecture purposes, these illustrations are quite helpful, but all credit is due to the author and illustrator of this text, author Roger Baker, and illustrations by Donald Alvarado. So here you can see the pathologist or autopsy technician is making the initial Y-shaped incision onto the body. I generally prefer to use a scalpel to do this. This looks like they're using sort of a large knife. The other thing to also note is that this book is from 1962, and the people performing the autopsy may not always be wearing the proper PPE here. As the incision is extending into the abdomen, I have seen many people use their fingers, such as this photograph depicts. However, I prefer to use a large forceps or hemostats with this same function. The function is to lift the abdominal walls to protect the bowel from being perforated while you're extending your incision. Next, it's important to expose the rib cage laterally by dissecting off the soft tissues. I once again prefer a scalpel for this task, as you frequently will encounter bone with the blade and need to change it often or sharpen it by the end of the step, so I usually use a scalpel in this place. This photograph depicts the removal of the chest plate. It's being reflected after the ribs have been cut with the rib shears, or you can use the electric saw at that step, but we aren't doing that because of COVID. Once the chest plate has been removed, the chest cavities are assessed for pleural and pericardial effusions. If present, the volume and character are documented. Following the opening the pericardium, the heart is removed while carefully assessing the presence of pulmonary emboli. In my experience, this is one of the most frequently missed gross findings by beginners in the autopsy suite and can make or break the case. This is an important step to understand and get right while you are learning, and a place for very careful observation by the supervising, attending, and pathologist. I am always physically present and hovering closely during this step, no matter how advanced the residents are performing the case. This drawing shows a post-mortem or current jelly clot, which you can see located in the pulmonary artery very near to the scalpel as they're removing the heart. Usually the right hand, if you're right-handed, you're going to be using your scalpel to remove the heart and pulling very tense traction on with the left hand, and that allows for you to see the pericardial reflection and make accurate cuts without cutting into the heart and get removal to be even. This shows the left lung being removed at the hilum. This is a common way to remove it during the Virchow technique. Once the chest cavity has been emptied of the important organs, the small and large bowel are tied off and removed, cutting along the attachment of the mesentery and pericolic fat. When completed and opened, the entire small and large bowel can be laid out flat for examination of the mucosa for any mucosal lesions. This may not always be the best choice depending on what you're looking for. So when you're looking for vascular lesions that have manifested in bowel ischemia or that is suspected clinically, for vascular dissection, I found it much more helpful to use the M-block method or Brokatansky method, leaving the bowel in situ to dissect the vessels primarily before removing the bowel from the mesentery. This drawing depicts the relative removal of the neck organs, including the tongue. Once again, I prefer a scalpel for this task as it is a more delicate area. It also fits nicely into such a smaller space and can be better controlled so you don't make unnecessary or inappropriate cuts. This is just another photo depicting the progression of the dissection as it goes so you can remove the tongue. This shows the incision for the removal of the brain. In general, I was taught to begin the incision behind the ear and angle it to the posterior aspect of the head, so the incision will not be visible during open casket viewing of the body. So this seems to be a little bit more anterior than I normally would choose my approach, but in general, this is how it's removed from the scalp is cut over the top of the head. Once the calvarium is open, the brain is removed easily with a few cuts to liberate the cerebellum from the tentorium, the ocular nerves, and the brainstem. The brain is optimally fixed for 2 weeks in formaldehyde and cut for examination. However, sometimes limitations set by the next of kin necessitate cutting a fresh brain the same day with all the other organs. Many forensic pathologists cut normal brains fresh without fixation. The final step in the removal process, the brain is going to come out of the calvarium and be inserted into a formaldehyde bucket and floated with a piece of string or sometimes in a surgical cap in order to allow for fixation for these 2 weeks before it's cut by the neuropathologist. This is an example of what you would see if you removed your organs en bloc and used the Brokatansky technique. These organs are removed all in one block. This is from the anterior aspect, so you can see all the organs are still in their anatomic locations. Advantages I've found to using this technique, it keeps the anatomic association of organs for the prosector. And sometimes this is very important for residents to see them in their anatomic locations, see how things orient to one another. And it can be very helpful for them to understand the autopsy process. However, this sometimes at very initial learning phase can be a very long dissection for residents, and sometimes it just gets overwhelming and they can be very tired. I mean, I've done autopsy with Rokitansky technique that's taken about 8 hours with the beginning PGY1 residents. That's one pro to this, as well as I choose to use it in very specific circumstances, because I do find that it does take a lot longer for sometimes for this technique. I use it when it's necessary for aortic pathology. Unexplained retroperitoneal hemorrhages, I'll always use it. So I'm looking for possible aortic pathology, as well as venous pathology. Unexplained hemothorax, cardiac tamponade, esophageal pathology, as well as such as varices, bleeding varices, or possibly a tumor, ischemic bowel, post-abdominal surgery patients. Things that I find detrimental to using this, or when I would choose to use another technique, it is in general unwieldy to handle for small-sized prosectors, so people with small hands like myself. And it also takes a lot of prosection space that, depending on how your autopsy suite is set up, you may not have available to you. Posterior view of the organ block, you would start with opening the aorta and tracing the branches to significant sites of bleeding when you're using this specifically for aortic pathology, and open the vena cava and then remove and dissect the kidneys and adrenals. The last step of the autopsy day for people who are performing an autopsy is the autopsy reporting. It is an extremely important part of the process. It is best done immediately following the autopsy, as all the findings are fresh in your mind. As you do more cases, you'll find that they can run together and overlap in your mind as you have more patients. You do multiple autopsies in a single day. Dictating the gross provisional is an important first step in completing the autopsy reporting. So gross provisional diagnosis usually has an outline that includes all of the parts and all of the findings on the gross examination. The final autopsy report will then be created as you work on the autopsy case, and usually that's 6 to 8 weeks later as you're looking at the slides. So the final autopsy report will incorporate multiple sections, including the final diagnosis, where you pull everything together, the clinical pathologic correlation, which is the opinion part of what is happening, what you feel like the clinical outcomes, how they correlate with the autopsy findings, and what your cause of death opinion is, as well as the gross examination is a separate section where you're dictating all of the findings of the gross in very detailed fashion, and the microscopic examination where you discuss all the findings on the slides, and then there will be any ancillary testing that you may have performed, such as toxicology reports or microbiology reports if you've done cultures, or PCR testing if you're testing for COVID. Things like that are actually included in the autopsy as ancillary testing. And then finally, usually we include the clinical summary, where we've gone through and done a chart review and discussed the clinical findings of the case, what the clinical doctors have seen as the patient was in their hospital course. So this is what the final result of the autopsy is, the autopsy report documenting all the findings. So if you have questions following going through this first part of the module, please feel free to send us via our email, pathelective.autopsy@gmail.com, and someone will respond to your question. Thank you very much for your time and attention.